Good afternoon. My name is Paul Wax. I'm the Executive Director of the American College of Medical Toxicology, and I'd like to welcome you all to our webinar series entitled Medical and Public Health Considerations of COVID-19. Today we will have two presentations. The plenary session will be on the use of neutralizing monoclonal antibodies as a treatment for COVID-19, and this will be followed by a shorter presentation on anaphylaxis from COVID-19 vaccine. I'd like to thank our webinar series partners for promoting this webinar series. Greatly appreciate it. This webinar will be recorded, and all the registrants will be notified on Friday that it will be up on our website. And all our previous webinars are also up on the website on demand at the URL at the top. We've also developed a series of web series FAQs, and these can also be found on our website at the URL address. There will be a Q&A at the end of the session, approximately 15 to 20 minutes or so. So I would encourage folks to put in their questions into the Q&A box on the Zoom platform, or if you're on the YouTube, you could also put the questions into the chat box. I'd like to thank my co-moderator, Dr. Ziad Kazi, for helping out with the moderation today. He's a board member of the American College of Medical Toxicology and president of the Middle East and North African Clinical Toxicology Association, and an associate professor of emergency medicine medical toxicology at Emory University. I'd like to introduce our plenary speaker today. Dr. Peter Chen is a professor of medicine and biomedical sciences and director of the Division of Pulmonary and Critical Care Medicine at Cedars-Sinai Medical Center in Los Angeles, California. And he's the first author on a landmark study on monoclonal antibodies that was recently published in the New England Journal of Medicine. It's really my delight to have Dr. Chen join us today for his presentation. Thank you.
Thanks for that introduction, Paul. I'm the division director at Pulmonary Critical Care here at Cedars-Sinai, and my usual job has been to do lab-based research. I have a R1 funded lab that does research in influenza-mediated lung injury, and during this pandemic, I had to repurpose myself to run a lot of clinical trials, and I linked up with a lot of the outpatient clinical trials for the antiviral therapies here at Cedars-Sinai. I'm also a frontline caregiver. I've been working in the ICU, and then also as division director, I had to coordinate a response towards COVID and reorganize our ICU to meet the demands. And so I've really seen this disease on all different levels. But what I'm going to talk about today is the use of neutralizing monoclonal antibodies as a treatment in COVID-19. And just to start with disclosures, I do have a paid consultation with Eli Lilly, but they were for projects independent of the monoclonal antibodies. So, currently we have been given emergency use authorization from the FDA for really 3 different types of neutralizing antibodies. The first one came in August of last year with convalescent plasma. This is only for hospitalized patients. And I am going to go through a little bit of convalescent plasma data as part of this talk today. But then in November of last year, both bamlanivimab and casirivimab and indevimab, the Eli Lilly and Regeneron products, were given EUA. They're quite a mouthful, so you'll probably hear me saying Eli Lilly product and Regeneron product throughout the talk. These are strictly for non-hospitalized patients that have mild and moderate COVID-19. They can be given in adults and pediatrics. And I'll go through a little bit of data supporting that and some newer data also. So to kind of start the talk off, I think it's good to understand how the virus works. So when the SARS-CoV-2 virus interacts with a cell, it actually uses the spike protein on top of the virus to interact with the ACE2 receptor. And what happens then is that it causes a conformational change in the spike 2 so that it helps, it is taken up by the cell, which then starts the viral replication cycle. And it reproduces tons of these viruses coming out of the cell, and in the process, it kills off this cell. And so if you kill off enough of these cells, it's going to cause damage to the organ, primarily the lungs, and then a lot of inflammation. And so what a neutralizing antibody does is it stops that process at the very front end. And so it binds the spike protein, and by binding the spike protein at the receptor binding site, it prevents this interaction with the spike protein with the ACE2 receptor. And so by preventing that, you never let the virus enter the cell, and then you stop this replication cycle. It can't damage the cell, can't kill the cell, and reduces the amount of damage that it does to the organ. So, this is a very busy slide, and I'm going to go at a very high level of the immunity towards viruses. And so when you're infected with a virus, you have what antigen presenting cells, and here they use a dendritic cell as a classic antigen presenting cell. And what that antigen presenting cell does is it chops up the virus. It takes all the proteins in that virus and chops it up into small little bits and presents it on its surface. On this side of the slide, where you see the CD8 cells, what it does is it trains these CD8 cells to recognize different peptides on the virus. And by training these cells, then the cells can recognize when any cell in the body has a virus, and it will go and destroy it. These are cytotoxic T cells, and they'll come and kill those cells off and really stop that process of replication. On the other side, you have humoral immunity, where it goes to the CD4 T cells. And these CD4 T helper cells also are trained to recognize the antigens, and they subsequently train the B cells. And by training the B cells, it tells the B cells how to make the antibodies towards these various antigens that is presented to it. So all these little things on the virus is chopped up, and now you make all these different antibodies that can bind the virus. And so when you have a whole mish of these antibodies, it's called a polyclonal mixture. Poly meaning many clones of the antibodies. And that essentially is what convalescent plasma is. You take out the plasma, you purify and then in it, you have the antibodies. But these antibodies not only bind this virus, but it binds really anything that that host has seen before. And also, we don't really know how much of these antibodies there are binding that. Now, that's where the monoclonal antibodies come in. What they did is they plucked one of these, and now they have one antibody, mono meaning one, clone of antibody. And the way they did that was they took a patient that was infected with SARS-CoV-2, and they screened for all the B cells in the blood. And after that, they were able to take the one B cell that made the one clone that bound the receptor binding site the best. They can immortalize this B cell. Now they have that B cell forever. And they can expand it, and they have these bioreactors that produce the single antibody over and over again. And so they can use it, purify it, and give it to patients as a therapy. And again, they selected the one that binds the receptor binding site of the spike protein. So what I tell people is monoclonal antibodies is essentially polyclonal antibodies or convalescent plasma on steroids, because we can produce this at very high levels. We know that it's high titer. We know it's specific to the spike protein, whereas in convalescent plasma, you have antibodies from all different types of antigens on not only SARS-CoV-2, but other viruses. And then also, you don't really know what the titer of that is. And so there are many advantages of the monoclonal antibody because, again, you can manufacture this now. So I'm going to quickly go through some of the convalescent plasma data to kind of set up the story for the monoclonal antibody. And early on in COVID, we're coming up to almost a year now that in the United States we've been dealing with COVID. The Mayo Clinic group had this expanded use for convalescent plasma. So many people started using convalescent plasma in COVID. And so the Mayo Clinic was an early adopter, and they used a lot of it. And so they published their data on it in the New England over last summer. It came out in press. And this is just modified from table 2. I kind of just took the highlights to kind of just move this talk along. But what they found, and this is an observational study. So observational study, they had to just get a reference group. But what they found was that if you take high titer versus medium titer, and you took the entire cohort, there really was no significance. The convalescent plasma really didn't have much effect. But then if you started fractionating the groups and you look at those that were not ventilated, essentially hospitalized and not as sick versus those that were ventilated, if you look at the high titer group, you can see that they actually look like they had some improvement in survival compared to those that didn't have high titer. That effect was lost when you looked at those that were very sick on mechanical ventilation. Moreover, what they found, and this was in the conclusion, it says they found that essentially if you give it earlier, they had a better effect in reducing death. And so this was kind of the first teaser that maybe if we give patients with high titer and early on, that you might, with convalescent plasma, be able to reduce the amount of death with patients that have COVID-19. So this paper came out in American Journal of Pathology afterwards, and it had very similar findings. And so here, essentially, it's all comers, matched groups. When they transfused convalescent plasma, there was no difference. When they looked at people that were within 72 hours, it was getting close, but still not significant. You look at people were greater than 72 hours, not even close to significant. And then you look at people that were given the infusion within 72 hours and also high titer, and then now you have significance. And so these studies together, both observational, were kind of giving a signal that if you give the convalescent plasma early on in the course and of high titer, you might have an effect on patients in reducing their mortality. Well, then came the clinical trials. And then that became a little bit less exciting because pretty much all these clinical trials here had no effect. It showed that convalescent plasma really had no effect in this disease. And so people started kind of questioning if convalescent plasma has a role in COVID-19. But I think there's a recent paper that just came out. It's in the New England. This came out a few weeks ago, published online on January 6th. I think this really starts giving us a little bit of clarity of where the space is for convalescent plasma. And what they did here was they gave patients convalescent plasma within 72 hours. So they focused on very early on in the clinical course. And they also looked at patients that were at high risk. Those that were over 75 years old or between 65 and 74 and having at least one of the coexisting conditions such as diabetes, renal failure, and things, essentially risk factors for severe disease. And what they found was that there was a difference in that convalescent plasma reduced the proportion of those that progressed to severe respiratory disease. And how they defined that was basically people who had a respiratory rate greater than 30 or had saturation drop to, I believe, less than 94. And so this was significant, and it was a pretty big drop of almost 50%. And so I think what all these convalescent plasma studies are demonstrating now is that we really have to give it early on. So the strongest effect is within 72 hours. You have to give in high titer, and it seems like the high risk patients may have more benefit, but all the studies did show that it is safe. And so one of the things to note about high titer is that most of the convalescent plasma that we collect probably is not high titer. And in our center, we recently talked about this, and only about 13% of the plasma we collect is actually of appropriate high titer. And there was an editorial that was when the previous New England paper, and they said at their center it was about 19%. And so you're looking at less than 20% that's high titer of your convalescent plasma. So you have a limited supply of this. And so you really want to maybe focus it on those that are early and those that maybe even high risk patients to really kind of save the convalescent plasma for those that have benefit. And so with that, I'm going to segue into the monoclonal antibodies. And like I stated kind of earlier on, monoclonal antibodies, we can produce this at high titer. So now we don't have to worry about what the titer is. We know this specifically binds the receptor of interest at the receptor binding site, and it's at high titer. And so there were 3 studies that have been to date that have been published on these monoclonal antibodies. 2 of them from Eli Lilly. I was part of these studies. And then there's the one from Regeneron, which had very similar effects. I'm going to give equal billing to all of these because I personally believe that all these antibodies are probably very similar. It's just that the studies are done a little bit differently, and the outcomes are all pointing towards very similar results. And so I felt the best way to really present this was in a kind of a summary table of all 3 trials. And I'm not going to go into the details of it. You can kind of dig into the papers yourself to get really into the nitty-gritty of these. But there was the first New England paper on the bamlanivimab. Then the Eli Lilly recently had a JAMA paper that's in press right now of a combination of antibodies. And then the Regeneron has always been a combo of these 2 antibodies. The inclusion criteria was very similar: non-hospitalized, greater than 18 years old, and enroll within 3 days of diagnosis. The Eli Lilly was 3 days, Regeneron was 72 hours, but nevertheless, roughly 3 days. So in the first study, and also the note, these are all phase 2 studies. And so the numbers are small. We did an interim analysis in kind of just getting the data out there of the studies. But again, phase 2 is not usually powered for clinical endpoints. But what they found was that when they looked at this interim analysis, first looking at placebo of about 143 patients versus drug. And in this first study, we had 3 different drug levels: 700 milligram, 2800 milligram, and a 7000 milligram. Roughly about 100 patients in each group. The one thing to note is that it was felt from the get-go that 700 milligrams was the saturating dose, and that this was more than sufficient amount of antibody in the system to suppress the virus that's in the system. However, we started these studies, our first discussions in these studies were back in last March, when COVID first started hitting us in the United States. And so we didn't have the luxury of having much information about the kinetics and everything about COVID. And so we had to make our best guess. And so they used a lot higher dose just in case they were wrong with that dose, because we didn't have the luxury of time. But what you're going to find in these studies is that we talk about pooled dosing, because again, we feel that the 700 milligram dose is the saturating dose, okay? So what we found in the primary endpoint, we chose a baseline change in viral load from baseline at day 11 was our primary endpoint in this first study. If you look at the 700 milligram dose, it wasn't significant. 2800 milligram dose, it did decrease virus and it was significant. 7000 milligram dose, not really much of an effect. Pooled dosing, not a significant decrease. And so that was not the most exciting thing to see. It didn't really have a significant decrease in the primary endpoint. However, I want to note that at day 11, what we found was that many of the patients already had either very low or no virus detectable. And so when you have a very low to no virus level detectable, it's hard to show a difference that's suppressed from that. And again, we had to choose very early on this endpoint at day 11 before we knew much about the viral kinetics. And so it did not help us in that respect. But when you looked at one of the secondary endpoints of combined hospitalization and ED visit, this is where we started getting a very interesting signal. 9 of the 143, roughly about 6% of the placebo group, ended up either in the hospital or having an ED visit. When you looked at the pooled group, 4 out of 309, roughly about 1.5%, had a hospitalization or ED visit. And when we looked at those in high risk, when we took patients that were over 65 or had a BMI over 35, this number even became more highly enriched in that the placebo had about 15% that had a hospitalization or ED visit, and the pooled dose had about 5%. And so that's a 10% difference, which is a number needed to treat about 10. There was no difference between the two groups when we looked at SAEs and AEs. And so it really showed that these drugs were safe. And so, this first study was, depending on what side you want to argue, it was not significant from the primary endpoint. Secondary endpoints have to be taken with a grain of salt. It's usually hypothesis driving type of endpoints. But we were finding a very good signal here, a very exciting signal that maybe we were reducing the amount of hospitalization and ED visits with this medicine. Then, recently Eli Lilly looked at the dual combination drug. Again, similar enrollment criteria. Placebo, 152 in the placebo. Drug had 109 with the two, and this time we used 2800 milligrams in both of these antibody levels. And they did find a significant decrease in viral load at day 11. But again, what's more important is when you look at the secondary endpoint of hospitalization ED visit, it's highly consistent with what we saw before. About 6% of placebo was hospitalized or had an ED visit versus about 1% of the treatment was hospitalized or had an ED visit. So again, replicating the findings in that it looks like there's a signal that this may reduce the amount of hospitalization and ED visits. Again, it was found to be safe. And then finally, the Regeneron product had a very similar trial. In their interim analysis, they had about 93 in placebo, and then their drug group, they had 2 different drug levels, a 2.4 gram and an 8 gram drug level, and again, about 90 patients in each of those. And you can see when they looked at viral level change from day 7, there was not much difference in the, at least not a significant difference in the 2.4 gram group. There was a significant difference in the 8 gram group. Combined, you did have a significant decrease in the viral load. But again, you look at the combined endpoint of hospitalization and ED visit, very similar results. The placebo had about 6% that were hospitalized or had an ED visit. Combined had about 3%. And again, they also found it was fairly safe. And so, altogether, these are all kind of giving us really nice signals that it might reduce the amount of hospitalization and ED visits for these patients. And so in this slide, this is not published data, and so you can take that with a grain of salt. But this is the BLAZE-1, which we continued the study as a phase 3. And we enrolled patients that were high risk, that were very similar to the EUA criteria of, and I'll go through that in just a second. But essentially, they had to be high risk patients. And now we looked at the primary endpoint of having either hospitalization or death of any cause. And so we had 500 in each group, a placebo group and a treatment group. We had a very large decrease in the number of events. 7.7% rate here, 2.1%, almost 70% drop, which is highly significant in the amount of either hospitalization or deaths between the two groups. More importantly, when we looked at deaths, there were 10 deaths in the placebo group. 8 of them were considered COVID-related, no deaths in the treatment group. And so now this data is really starting to come together, now that we have more patients and looking at a clinical endpoint as our primary endpoint, that this treatment does seem like it's going to reduce the amount of deaths and hospitalizations for patients. And so the data is getting stronger and stronger. Like I said, this is not published yet. It's only in press release. And I can tell you that the paper is about to be submitted. So the other thing to note with these monoclonal antibodies, it has not been found to be beneficial in hospitalized patients. This is the ACTIV-3 study. There was an ACTIV initiative that was run out of NIH. It basically co-opted a lot of clinical trial networks. One of them is the PEDAL network, which we are involved in. And so what we tested was the monoclonal antibody from Eli Lilly. This was done last summer to see if it had an effect in hospitalized patients. And these were hospitalized patients that were not ventilated. And what we found, if you just look at these Kaplan-Meier curves, that there just was no difference in sustained recovery or time to discharge. And so, it was a negative study. And so the monoclonal antibodies are not felt to be beneficial in an inpatient setting right now. So this is the EUA criteria for giving the monoclonal antibody. Now, one thing to remember is that the patients have to be given this within 10 days of their development of symptoms. They have to be outpatient and they can't be on oxygen. Now, there is a caveat. If they are hospitalized for some reason that is not because of COVID-related illness, then you could make that argument that they can be given, but for the most part, they should not be given to hospitalized patients. And so in adults, you can give it to those that are greater than 65, have a BMI over 35, either have CKD, diabetes, or have immunosuppression either from underlying disease or on treatment. Or if they are greater than 55 and have cardiovascular disease or hypertension or COPD or some other respiratory disease. And so these are the criteria for giving adults. In kids, you can give it between the age of 12 and 17 if they have a BMI over 35, sickle cell disease, congenital acquired heart disease, developmental disorders, medical-related technology dependence, or asthma, reactive airway disease, or chronic respiratory disease. And so this is the criteria for when you can give these monoclonal antibodies. And so this is how we do it at Cedars-Sinai. We have an order set that our physicians or caregivers, any caregiver can prescribe with patients that are diagnosed. Again, they have to be within 10 days of symptoms in order to fit that window. And so it's sent to the pharmacy. The pharmacy has to vet this. They make sure, double check that they met the EUA criteria, and they also make sure that they are within 10-day window. And so then they schedule it. And we've gotten a lot better at scheduling where we can almost give this the same day now if it's an early morning order versus next day if it's in the afternoon. And then we schedule them for an infusion. It's a 1 hour infusion and 1 hour monitor. Now this changed recently that the Eli Lilly product can actually be infused within 16 minutes now. So we can infuse at a lot faster rate. But we bring them to an infusion center and give them this antibody. And so, you know, the problem with this is that it's most infusion centers have cancer patients. And so that it's very difficult to find these spaces to infuse the patients. But we were able to make it work. I've heard of some people using tents and other space to give these infusions. And one of the things to remember is you have to monitor for 1 hour because you have to monitor for anaphylaxis or any kind of infusion reaction. Throughout the trials, we have found a few. It's been a very rare event, but it can happen that you can have that infusion reaction. But we personally have not seen any infusion reactions. Throughout all our trials and also giving the EUA, we've probably seen over 1,000 patients now. And we have never had any infusion reactions yet, but it can happen. One other thing we've recently done is we started partnering with home infusion services. And so that when we get an order, we send it to the home infusion service and they actually set up the infusion to give the monoclonal antibody either at home or somewhere else. And I've actually been talking to some CMOs of dialysis centers and so forth, where they're actually giving it in their centers also to COVID patients. Also, one of the things is CVS Quorum has a service now where they're actually getting this. And so you can actually, they're doing pilot programs in several cities throughout the United States. And you can send the prescription to CVS Quorum and they will actually handle the rest from there. And they will go to the house and infuse it. So I'm going to stop or finish the talk with talking a little bit about mutations, because there's been a lot of angst, I guess, in the about these mutations that are popping up with COVID, the SARS-CoV-2 virus. And one of the things you have to remember is that we've always known that RNA viruses would mutate. And RNA viruses tend to be on the high end of the scale of mutation. They tend to mutate at a higher rate. It's pretty much because they use what we call RNA polymerase and not DNA polymerase, which RNA polymerase just doesn't have as high fidelity, doesn't have the proofreading of the DNA polymerase, and therefore you can introduce a lot of mutations into it when you're replicating the RNA. But the thing to remember about mutations is there are good mutations, there are bad mutations, and there are neutral mutations. If it's a bad mutation, the virus can no longer replicate, it loses some kind of fitness, and so it doesn't keep up with the rest of the viruses and it will eventually drop out. However, if it's given some beneficial mutation, then over time, it can actually develop some kind of advantageous effect that will let it come out in a population. Say, for example, if you can run faster from someone else, over time, you're going to end up having a much longer lead in that race than someone else. And this is essentially Darwinism. It's natural selection at its best. And the way that I thought would be an easy analogy to describe it is thinking about antibiotic resistance. If you have a bunch of bacteria and a couple of them are resistant to an antibiotic, and then you treat that patient with an antibiotic, and you start killing off all the bacteria that are susceptible, but the bacteria that are resistant cannot be killed, they will start growing, and then they will become the dominant population. That's essentially what's happening with these viruses, is that they are mutating and generating some kind of fitness that lets them exceed above the rest of the population. If they can get in the nose better, they can survive better in the oral pharynx, something that is letting them survive. And so, you know, when I first started putting this together, we were talking a lot about the UK variant. Now we're talking about, you know, the South African variant or the Brazilian variant. There's going to be more variants to come. You know, one of the things that we saw, if you look at when they sequenced the variant in the UK, was that very quickly, this is back in October through December, you can see that it took off. And it's because it had something that allowed it to basically either infect someone else easier or stay in this environment a little bit longer than these other viruses that gave it a fitness to come out on top. And so, can these variants escape monoclonal antibodies, these neutralizing antibodies? And so I decided to draw a little cartoon to kind of explain what might happen. And so this is the virus, this is the spike protein, and this is the receptor binding site where the antibodies bind, okay? And so this is where it interacts with the ACE protein. So if you look at these combination antibody products, for example, the Regeneron product, or the newer version of the Eli Lilly, the new trials we've been using 2 antibodies. They will bind 2 different regions of this receptor binding site, 2 different epitopes, essentially. And they will block that this receptor binding site from interacting with the ACE2 receptor. Now, we start having mutations, as we expect, along the spike protein, as denoted by these different colors. If they happen in a spot that's not the receptor binding site, not going to have an effect, because the epitopes still bind the antibody's still going to block that virus from entering the cell. Now, if you start having mutations in the receptor binding site, it can knock off one of these antibodies and prevent that interaction if it is at the right site, exactly on the spot of that epitope. So these are all random mutations to date. And so, there's not enough selective pressure in the environment for these antibodies to select out for these viruses to be resistant. But if by chance you have the right combination of mutations that hit both sites, then both antibodies won't be effective in suppressing it, and essentially is rendered useless. But Regeneron did some studies. It was published in Science a couple months ago, where they showed that using the dual antibody combination, they can actually reduce the amount of these escape mutations from happening. And so we think that using 2 or 3 antibodies probably will not lead to resistance to the actual drug. And I can tell you also, we're testing a new antibody right now. It's from GSK, where they've partnered with Eli Lilly for the outpatient studies, but it also is being used in the inpatient ACTIV-3 studies. And this GSK antibody was found with the original SARS virus, the SARS-CoV virus. And it binds the receptor binding site in that original virus, as well as in the SARS-CoV-2 virus. And so it's a highly conserved region of the receptor binding site. And that would suggest that it's a region that can't be mutated, because it's conserved over time. And that if you mutate that region, as I said, that it might be a detrimental mutation that the virus can't survive. And so that is something that might be coming down the pike for us. So just kind of in conclusion, I've already talked about the convalescent plasma. We want to give early, the data showing that you want to give early in 72 hours. These are for hospitalized patients, and high titer has more benefit. And then it seemed like it has more benefit for those at high risk. But then the monoclonal antibodies also, our studies are showing that it's better within 72 hours. The EUA gives you 10 days within symptoms, but our studies were designed to be 72 hours within the diagnosis. And it's not at this time shown to be beneficial in hospitalized patients, and so it should not be used in that setting. And it seems like it has a more dramatic effect in those of high risk, and both of these seem to be safe. So I'm going to end there and pass the mic.
Well, thank you very much, Dr. Chen. That was really an excellent and extremely timely presentation. We have dozens of questions in the queue, and we will get to them very shortly, and feel free to continue to put in your questions. It was really a wonderful presentation. Well, at this time, I'm going to share with the audience an update regarding anaphylaxis from the COVID-19 vaccine. And let me see, go to the next slide. Okay, let's go back one slide. Okay, so ACMT, the host organization for this webinar series, has recently put together a pharmacovigilance project looking at adverse drug reactions from COVID therapeutics. This has been funded by the FDA, and we're really delighted to be able to stand up this program, which really just got going in the last several months. This is part of our Toxicology Investigators Consortium, which is an ACMT multi-center research group. And for this particular project, we've stood up a multi-center program at 15 university medical centers across the country. Just really getting this all stood up over the last 8 weeks or so. And we've been reporting on adverse reactions to a variety of drugs that are used either in the treatment of COVID-19 or drugs that people are also taking at the time of their treatment for COVID-19, and also some drugs that people are using prophylactically to potentially prevent COVID-19. So a number of different drug categories we've had cases submitted from, but most interestingly are the cases regarding the newer therapeutics, particularly the antivirals, and now starting to get some cases on the monoclonal antibodies and vaccine cases. So these are the numbers to date. They're still relatively small, but we've just stood this up literally in the last few weeks. One of the vaccine cases is a very interesting case, and I want to present that. It's a case of anaphylaxis. And before I get to the actual case presentation, just review some of the recent data that's come out. So this was an MMWR report on the first 10 days of the Pfizer vaccine, and the incidence of anaphylaxis in this series was 11 cases per million doses. And also of interest that 71% of these cases occurred within 15 minutes of vaccination. And this is important to keep in mind. There's some subsequent data that's been reported from the Pfizer vaccine where the number of cases may be actually lower, maybe more like 5 cases per million doses. And this was a paper that just came out just last week looking at the Moderna vaccine, and the anaphylaxis in this case was 2.5 cases per million. So again, very tiny number of cases. And in this series, the 9 cases, 9 out of the 10 cases occurred within the first 15 minutes after the vaccination. So before I get into the case presentation, I just want to go over the definition of anaphylaxis, just so we're all on the same page. And it's a clinical syndrome characterized by sudden onset of the symptoms, a rapid progression, and involving at least 2 organ systems. And so for the level 1 diagnostic certainty, there has to be at least 1 major dermatological finding and either at least 1 major cardiovascular and or respiratory finding. And this is a pretty well recognized diagnostic criteria. And so the major systems dermatologically either include generalized urticaria or angioedema, cardiovascular, it's hypotension generally, and respiratory, it could be wheezing or stridor or upper airway swelling or respiratory distress. So this is what defines anaphylaxis. So this case was a case of a 30-year-old female healthcare worker who received her first dose of the Pfizer vaccine. Now, she had no documented history of reactions to previous vaccines, but she did have some allergies to a couple of drugs. The second of which is used for migraine treatments, is an injectable drug. And within 5 minutes of receiving the vaccine, she developed hives on her neck and chest, some lightheadedness and flushing, and some shortness of breath, wheezing, and throat swelling, which would be consistent with anaphylaxis. So she presented to the emergency department. She had a pulse rate of 100 and a respiratory rate of 25. They don't seem to have recorded the blood pressure. And she was treated with epinephrine, and she gradually improved and was sent home rather quickly, 3.5 hours after presentation, with an EpiPen, as well as prednisone, hydroxyzine, and famotidine. And this would be a typical case of anaphylaxis. However, on the next day, she again developed some shortness of breath, and her husband administered the EpiPen that she'd received, and they called the EMS, and they arrived. They gave her some additional epinephrine and diphenhydramine, and they brought her back to the emergency department. At this point, she was actually in worse off shape. She had an altered mental status. She was diaphoretic, tachypneic, tachycardic, and had some stridor. Her pulse rate was 140 and her blood pressure was a little bit high, respiratory rate 23. And she was given multiple doses of epinephrine and steroids and antihistamines, and she was started on an epi drip. But the stridor continued and she wasn't responding to the nebulized albuterol. So in fact, within 45 minutes of this initial presentation, she was intubated and placed on mechanical ventilation. So this was really a dramatic case. She was admitted to the ICU, weaned off the epi, and extubated the next day. And after some monitoring on the hospital floor for an additional day, she was discharged with no residual symptoms. On the initial report into our reporting system, I thought that was, the extent of the case. But then we subsequently learned that that was not the end. And in fact, she returned to the hospital for a third time, again with stridor. She was intubated for the second time, admitted to the ICU. She improved and she went home. And once again, she went back to the hospital for the fourth time with stridor. She was not re-intubated, but she was put in the ICU and discharged home. So these subsequent presentations, didn't sound like typical anaphylaxis, and this was thought to maybe due to vocal cord dysfunction, although she had no history of this vocal cord dysfunction, but she did have a history of anxiety. The serum tryptase, which is often helpful for anaphylaxis, was not obtained on the first 3 visits. It was only obtained on the last visit, and it was negative. So in terms of what the assessment for this very interesting case, it seemed that the initial ED visit and even the repeat visit seemed consistent with, severe anaphylaxis. She had the skin changes, the findings in respiratory distress and stridor. But the subsequent visits may have been at least partially psychogenic, but it wasn't totally clear. This could have been from the vaccine or from the trauma, from the anaphylaxis. And there were a few objective findings noted on the later visits, like uvula inflammation. So it may have been from physical trauma to the airway. Again, it was not clear, a very unusual case. So there are reports in the literature of this psychogenic respiratory distress. Many folks may not be aware of this condition. It's a very uncommon condition, but these patients seem to develop this paroxysmal laryngospasm and often can be diagnosed by an ENT by direct laryngoscopy, which I don't believe was done in this case. So given the fact that millions and millions of people are going to get the vaccine, one should at least be aware of this condition. So is the vaccine safe? Yes, I think that's the major message here. And when you look at the numbers, the anaphylaxis rate on the initial reports are 2 to 11 per million, but death from COVID-19 is 3 orders of magnitude larger. If you use a 0.5 to 1% fatality rate, that's 5,000 to 10,000 per million. When you look at daily deaths nationally in the US, approximately 24 people per million die every day. That's just the baseline death rate. So anaphylaxis is less common than that. And then when you look at the total number of people that have been vaccinated already, that exceeds the number of people that have developed COVID-19. We have maybe a few dozen people that have developed anaphylaxis. We have almost 500,000 people that have died from COVID. So clearly the vaccine is safe and much, much, much safer than getting COVID. So at this point, I'd like to end this presentation, and I'm going to turn it back to Dr. Kazi, who will open up the Q&A. Thank you very much.
Thank you, Dr. Wax. That was a fascinating case and makes us think a lot about the next several months that we have ahead of us. I'm going to start first with some questions to Dr. Chen. And also want to invite our viewers to consider staying beyond 4 o'clock Eastern. We're probably going to stay till 4:15 p.m. to cover a large number of questions we have in the queue. So I'll start with Dr. Chen. We have a couple of themes here that I want to discuss with you based on the questions. One of them is about the indications for the monoclonal antibodies, particularly with some special populations, such as people that have autoimmune diseases and adults that have neurodevelopmental disorders. Is it safe and is it beneficial in these subgroups of people?
Yes, as far as we know, it is. We've given it to all types of patients. We've given it to those that have autoimmune diseases. We've given it to transplant patients, cancer patients, cancer survivors. We've done the whole gamut. And these antibodies are, for the most part, very well tolerated. You hear about the few cases of anaphylaxis or infusion reactions here and there. But overall, we've had a very good success without very many side effects from it. And I attribute that largely to the fact that the way that we identified this antibody, if you think about it, we plucked it out of a person that was infected with SARS-CoV-2, and we took the B cells. And so this is a fully humanized antibody. It's a human antibody. And so when you infuse it into a human system, the body really isn't going to recognize it any differently from one of your own antibodies. And one of the, and we've been doing these biological therapies for 30 plus years now. But really the difference between this biologic versus those that we give for rheumatoid arthritis, cancer, so forth, is that those biologics are designed to hit some receptor in your body to either turn it on or turn it off. And so when you're starting to turn on and off certain pathways, signaling pathways, you're going to have side effects from that. All this does is it binds the virus and prevents that virus from causing further damage and replicating. And they've done other studies where they show that it doesn't cross-react with the body, it doesn't cross-react with a lot of stuff. And so we know that this is very specific because the immune system developed it. And so that's why we actually believe that it's been such a good drug and not having that many side effects.
As a toxicologist, we administer antivenom. And I want to ask a question about the mechanism of this monoclonal antibody. You mentioned at the beginning it binds at the moment of the viral binding with the cell, or does it also bind virus that's circulating in serum, in the blood?
It binds all the virus. It basically.
But it doesn't have to have the cell.
Yeah, it's just binding all the viruses where it has the epitope it can see, and it will just basically, saturate it so that it can't interact with that cell anymore.
Excellent. Now, there were also some questions surrounding availability of these therapies. For example, what is it? What is being done to make sure this drug is available to our most vulnerable populations, including in rural areas, as well as the cost of this therapy, and then how it compares to the cost of convalescent plasma, please?
Sure.
So those three questions.
So the availability right now is all distributed through the states. So when the EUA was given to these antibodies for both the Eli Lilly and the Regeneron products, they basically donated, I can't remember how much, maybe 500,000, I don't remember the number. They donated a whole bunch of it to the federal government. And then the federal government gave allocations out to the states based off of, my guess is, distribution of where the COVID was. And then the states had their own allocation system of giving it to the hospitals. And so, in order to figure out how to get it, you'll have to go to your own individual state. When it first started, we were worried that there wasn't going to be enough antibody to go around because, they're currently manufacturing more and more, but we were worried that we were going to completely use it all up at the first get-go. And what we actually end up, seeing was that people just aren't using it. I actually sit on an academic advisory board on California State for COVID, and they were telling us how, they basically were allocating it to all the hospitals based off of their COVID numbers, and there were hospitals that just turned it down, and they said no, thank you. And so then and I think people are still trying to understand. I think there are a lot of people that just don't know about it, but then there are people that don't believe in it. And then it's not an easy thing to give, and so there's only certain places you can go right now. And unfortunately, those rural centers are the ones that may have more challenges in giving this. And so unfortunately, they are kind of left out of this in many ways. But if they can, find that space to give the infusion through the ED or some other space, then that is definitely something that can be started up pretty easily. Because the antibody's there, it's free right now. It's completely free for the antibody. You only have to pay for the infusion costs. And in our experience, insurance is paying for the infusion costs, and so there is no cost. So in that sense, it's cheaper than convalescent plasma. At some point, they will be charging for it at some point. It's just that right now they've donated all these drugs and it's completely free of charge.
So it's more available than convalescent plasma. That's great. Now that does bring up some other questions in the queue. We're interested in knowing about the emergency use authorization. And as I discussed with you before we started the webinar, I believe some of the issues are, the criteria may be restrictive or confusing a little bit. And I think one of our viewers asked the same question about the difference between 72 hours from your onset of symptoms, or 72 hours from the diagnosis, versus the 10 days from onset of symptoms. Can you maybe comment on that, and how the emergency use authorization criteria that you showed were determined in terms of this variety of diseases and ages,
Sure.
etc.?
I can actually tell you exactly how it was determined, because so the 72 hours was based off of the way we designed the study. But the EUA actually says you can give it within 10 days of symptoms. My personal bias is that we want to give it as early as possible, because that's really where you're going to have the most benefit. But as long as they're within 10 days of the start of the symptoms, they qualify within the EUA guidelines. Okay, and I think I read in one of the questions, you don't have to be over 65. Over 65 is one of the criteria, but if you're 18 and your BMI is 35, you qualify. If you're 20 and have CKD, you qualify. So all those others are, it's a or, not an and on those criteria. So if you're over 65, if you have a BMI over 35, if you have CKD, diabetes, or if you're immunosuppressed for whatever reason, any of those, if you have any of those checked off, they're qualifying for you to get the antibody. If you're over 55, then you have to have either cardiovascular disease, hypertension, COPD, or chronic respiratory disease if you don't have those other things I just listed off. Okay.
Yeah, this is quite inclusive, actually, very inclusive set of criteria. Now, what are your thoughts? And I know you and I discussed that with Dr. Wax earlier, but maybe the viewers would love to hear your thoughts about potentially one day, and deviating from these criteria and administering it maybe on an empirical basis when you suspect the diagnosis in your patient, knowing that we have some delays in the confirmatory test with the PCR.
Yeah, right now we can't deviate from it, because it's we have to stick within the EUA. Obviously, if it were to eventually get FDA approval, people always tend to kind of take their liberties. I think that's just the general way we do our practice of kind of expanding where we might want to use it as off-label. But I think what we were saying earlier was that these trials were very strict in what they studied. But there's still a lot of gray of kind of where we don't know, where people fall through the cracks. And so I think you have to kind of use your best judgment. I think for hospitalized patients, it has shown not to be beneficial. But like I stated, it is allowed in hospitalized patients if they're hospitalized for something else that's not COVID related. We've had people that came in for a procedure and we do a COVID test and it ends up, it's positive. And so if they're a high risk and they're like, oh yeah, I got exposed to someone 2 days ago and I just didn't think I got it, that might be someone you'd want to do it in, And so I think you have to use your best judgment. But I think what all the studies are showing is that it works. It works best in high risk patients, and it works best early on in the disease course. You wait too long, it's just not going to have that effect, because you're kind of past that viral part of the disease and you're more into the inflammatory part.
It makes sense. I mean, we do that, and you pointed it out. We do that for antibacterials, all the time. We try to give it early. Now, regarding the question vaccination. So one of our viewers was asking a really good question. So he had a patient apparently that received the 2 doses of the Moderna vaccine and then developed COVID. Can they get the monoclonal antibody? Say they fulfill the EUA criteria? Was there an issue there with the vaccine?
So they can. It's not specified in the EUA as far as I know, because when it first came out, we didn't have vaccines yet. That if you have the vaccine, you cannot get the antibody. We have done it here for those that got the vaccine, because you have vaccine failures. And so people can still get COVID, and so they should have the treatment just like anyone else.
Can you recommend based on the kinetics of the monoclonal antibodies, when would be a safe? Because I think the CDC would say consider waiting a couple of weeks after the monoclonal antibody to get the vaccine.
So that's actually defined in the guidelines. They say 90 days. The reason
90 days, I'm sorry, 90 days was for people that got infected. But I was asking if you've gotten the monoclonal antibody, when can you get the vaccine?
90 days. And
90 days, wow.
So these antibodies, I don't know about the Regeneron, it's probably similar, but the Eli Lilly antibody has a half-life of 17 days. And so, it's, 3 half-lives is 90% roughly. That's 45, 50 days down the line. And so the antibodies will still be floating around for quite a while. The 90 days is really out of abundance of caution. We don't know that the antibody can, if it will affect the ability of the vaccine to generate the proper immune response, right? Because you're producing a spike protein, it'll be binding the receptor binding side of it. And so you could feasibly say that maybe it's going to block that ability of that vaccine or the vaccine to produce antibodies towards that. I'm not sure I totally buy that idea, but that's what the CDC recommends right now, is that you should wait 90 days after you get the monoclonal antibody. And honestly, I tell everyone, waiting 90 days is no harm, no foul. Because first of all, like I said, the antibody will sit around for a while. Secondly, we know, and I know based off of some of the studies, data from our studies, that you will generate an antibody response after getting the monoclonal antibody, okay? And so you will generate immunity towards SARS-CoV-2. And therefore, we know that you have immunity for at least 90 days. And then now that, that was based off of data months ago. There's more recent data that shows you can have immunity up to at least 8 months. And as we go down farther down the line, we'll get a better idea of when people start losing that immunity, because we just don't have the lead time right now to figure all that out. And so if you wait 90 days, you're probably still going to be immune. So it's not going to hurt you to wait 90 days for that vaccine.
Excellent. Just to make sure I did not confuse the viewers. So if you are considering getting a vaccine, wait 90 days after your monoclonal antibodies. And if you are vaccinated and then develop COVID-19, then you can just get treated like anyone else, including the monoclonal antibodies. Excellent. That's great. What about, I have a couple of questions about the convalescent plasma, if that's okay. One of them was, can you pool plasma for different the donors to get a high titer?
So, well, what ends up happening is if you pool donors, you end up diluting the high titer, right? Because let's use the example of 1 out of 5 of the plasma are high titer. And so you pool every 5 by, just hopefully by random chance, you're going to get some titer in there. Well, you're going to dilute that titer by 1/5. And so is that going to be good for you? I don't know,
And then can you talk a little bit about what a titer means? I mean, I know you've talked about the doses, the evolution of the dose of the Eli Lilly product. So how do you all determine that this is a good titer, have a high titer, what is good enough?
Yeah, so that's more on the lab side of things, the blood bank. I don't know what their cutoff is, I'll be honest. I know that when the EUA first came out, I think there was like one specific test you're supposed to use to determine if it's high titer. And essentially a titer it's a neutralizing assay where you do a serial dilution of the antibody until it doesn't work anymore. And that gives you a sense of what the titer is.
That's coming up a lot nowadays because people that had COVID already, and when they're considering to get vaccinated, they go and measure they go and get a serology test, which gives them a number, but I don't know if this is really a useful number, or do they need to get a special test?
I don't think that's useful at all. I think that's false hope. There's been a lot of studies out here that have come out that show that people who had mild infections, we know that if you have mild infections, you tend to have lower titers of antibody. And there's studies that have shown that if you take the patients that were infected and you can't find any antibody in their system, if you pluck their cells out, you can actually find the cytotoxic response, and you can induce the B cells to generate more antibody. That's immunity. That's what our immune system does, is that it has this memory. And so if it's re-challenged, it comes back up in full force very quickly. And so just not having an antibody level doesn't mean anything. And so I actually tell my patients, don't check it because it's going to freak you out if you don't have it.
That's good advice. Okay, great. Moving along on some other questions here regarding the, let's see, regarding the administration. I was really impressed by the various strategies that are being, developed, including this pharmacy thing and the home health service. What about nursing homes and long-term care facilities? Are they picking this up?
Absolutely. And so I think that they actually would be high targets for this. So there was another study called the Blaze 2 study that Eli Lilly conducted, and I wasn't part of that. And so I can only kind of very superficially talk about it because I know about it. And they recently, again, released their stuff in press release. So you have to take all that data with a grain of salt. But they're not going to make up the results because they're going to publish it eventually. Essentially, what they did was when a nursing home had an outbreak, they actually had an RV that they sent to the nursing home, and they gave the antibody to everyone, those that had positive infection and those that didn't have infection, including the staff. And I don't remember the exact numbers of what, I want to say it was about 200 patients that they had in the study. And in the press release, I remember what was striking was that in the patients who were infected with COVID, they reduced the number of deaths with the treatment. Wow. In the nursing home. And in the patients that didn't have COVID at that time, they reduced the number of symptomatic COVID, so reduced their symptoms if they did develop COVID. And I want to also say that they did also have a signal in reducing the amount of death. I don't remember if it was a phase 2 or 3. I don't remember the details of it, but it was very striking results. And so what we've done in our system is that, in our ED, if we have patients that are sent to be evaluated from a nursing home or whatever, or SNF or something that has COVID, if they meet the EU criteria, we give them the shot and send them back with a shot.
Excellent. Well, that's really fascinating considering the asymmetric effect on our long-term care facility residents and staff. Having these options tested and tried is definitely good. Before I turn it over to Dr. Wax, Dr. Wax, I have a couple of questions for you. We may have some more questions for you, Dr. Chen, so stick around because the list of questions on the Q&A is ballooning up, so I'm gonna have to try to catch up on them. But Dr. Wax, can you tell us more about tryptase? You mentioned this test. One of the viewers was asking, what is serum tryptase?
Well, it's released from mast cells. It's an enzyme, so it can serve as a marker of an anaphylaxis reaction. But usually there's a window which starts about 30 minutes after the onset of the reaction. So if you measure it too early, you may not pick it up. Usually 30 minutes to 90 minutes or so would be the ideal window to pick up the mast cell degranulation. It's a marker.
Now, we've heard from the CDC that polyethylene glycol is one of the issues here. Is polyethylene glycol commonly used, Dr. Chen, in the monoclonal antibody? Are there any components of the monoclonal antibody that we need to be aware of as well, or?
I don't know all the components, but I have not seen anything about polyethylene glycol when I've done all my, reading on it. So I don't think it's in there, but I don't know for sure.
Thank you.
So it's concerning that, in terms of, taking a good history in terms of whether someone, should get the vaccine or not. If they've never received the vaccine, obviously you don't have that as a history. And whether they've had an allergy to polyethylene glycol or polysorbate, which are two of the components of the vaccine, most people are going to be totally unaware of. Now, previous allergy to injectables certainly should raise a possible red flag. And as it turns out, the case that I presented, she did have a previous allergic reaction to an injectable. So that may have been a red flag that was potentially missed. But the questions often come up, okay, so on the first dose, they had a reaction. What do you do about the second dose? And we're still gathering data on that. I mean, if they've had an anaphylaxis reaction to the first dose, you should not get the second dose, period. Now, if you want the second dose and you want to be careful about receiving it, the CDC recommendation is to consult with an immunologist or an allergist. So that's what I think is definitely in hand. Whether you should suddenly pre-treat someone with steroids or antihistamines like we do with other medicinals that will give despite a previous history of an allergy. There's just no guideline yet for that sort of approach. So I think consulting with an experienced allergist would be the best condition. Now, if you've had a more minor reaction, but it's to the COVID-19 vaccine, there should be some concern about again giving the second dose, and probably the best thing to do again would be to consult with an allergist.
One of our colleagues who's a regular viewer of our webinars, Dr. Frank Walter, just sent me in the chat box a Daily Med description of the contents of the, I believe the Regeneron product contains polysorbate, actually, just as an FYI.
Interesting.
Thank you, Dr. Walter, for sending that our way. Dr. Wax, would you like to ask some questions to Dr. Chen as well? I know we have tons of questions on the list.
Yeah, sure. Yeah, I think, you've been keeping up with which questions have already been asked. So maybe you should continue this. I know there's some, still questions about the accessibility and folks really trying their best to get the monoclonal antibodies. And, if someone's not connected, they don't have a primary care doctor, they don't want to go to the emergency department. There's not exactly a 911 number to call. Do you have any recommendations?
I'm sorry, is that about?
If they're really not, integrated into the healthcare delivery system, they don't have a primary care doctor.
Yeah.
They have the onset of symptoms. I mean, where do they go first to get, the monoclonal antibodies? How do they get into the system?
What I'm hoping is that we can start having our urgent care start ordering this, and that would be a possibility of. It's about getting people kind of aware. It's about awareness of what's available, and I'm hoping that if once we get the phase 3 published, that people will really start buying into it and having widespread use. Because in order for this to work, to really save people, save our hospitals from having hospitalization, you have to give it to a lot of people. It has to be really kind of massive in that respect, and so. It really has to go through our PCPs and urgent cares and so forth. And so if people don't have a PCP, then hopefully we can get an urgent care and then they can put that order in, because we've been trying to streamline our process where the physician or nurse practitioner or whatever can order it and not come to our infusion center and just go straight to an infusion service and then just have it done that way.
Dr. Chen, when you give the monoclonal antibody, one of our viewers is asking, can you tell how many days it needs to have an effect? I don't know, this data may not be available, but I thought I'd just ask it of you.
So what the data does show is that it will reduce symptoms faster by like a day or two. In general, I can tell you that when we give it to people, it's quite interesting because a lot of people actually feel much better very quickly. They'll oftentimes go home and have kind of a what we call the cytokine release syndrome, where they might start having a little bit more chills, fevers, achiness. It tends to be very mild and short-lived. Usually within 12, if not 24 hours, it'll go away. And then after that, they oftentimes say they feel great after that, and everything just melted away. And so you might have an initial increase. And so the cytokine release syndrome essentially is when you give the antibody, the antibody is binding the virus. And so your immune system now recognizes the virus better. And so it's going to start having a little bit more inflammation, but then that will quickly clear the virus. And then it all dies back down within, again, like I said, 12 to 24 hours. It's kind of anecdotally what I've noticed.
Yeah, so just as a follow-up to that, so in our surveillance system of ADRs from COVID therapeutics, of the dozen or so cases we got from the monoclonal antibodies, some of the symptoms have been lightheadedness, hypotension, and headaches, and there was one case of burning in the lower extremities. Are those the sorts of symptoms that you might have seen in your trial, or would be consistent with the cytokine release syndrome?
I think they can all be consistent with that.
Okay.
We've seen a number of things. I remember when we first started it, we've been doing this since the phase 1. And if you remember from the first trial, they had a 7,000 milligram dose, a very high dose, 10 times what we are giving now. And I had one patient say that they could smell it in their skin. but that we've had people who've had burning sensations, and things like that. So all of that could be consistent.
Dr. Chen, a couple of quick questions. Someone was asking if I've received the COVID vaccine, can I donate plasma for convalescent plasma?
I was actually wondering that same question today.
Okay, we can ask that question to some of our
it's not really my world. What I do know, what I've heard through our blood bank, is that people who get the vaccine have very high levels of antibodies. And so it's an interesting question. I don't know the answer.
Okay, a couple more questions, I think, before I turn it back to Dr. Wax. If you develop, two questions regarding the mutations. One is whether the treatment with monoclonal antibodies, a one-time treatment, is it enough to cause some pressure for the virus to mutate and no longer respond to the treatment? And then the second question, the follow-up on that is, let's say there is a mutation that affects those binding sites. How quickly can a company make a new monoclonal antibody? Is it pretty simple, the process, now that you have kind of done all the legwork?
So, the first one, if you, what the Regeneron paper showed in the science paper, they showed that essentially if you use the combo, it reduces the chance of you selecting out these mutants, okay? If you use a single, it could have a higher chance of selecting out mutants. But you have to remember, in order for that to become significant, you essentially have to treat someone with the antibody. They have to have a resistant mutant that then infects someone else to propagate, and that mutant has some advantage to continue outpacing the other virus that's out there. And so in theory, it can happen, but a lot of things have to fall in place for that to happen.
Plus, it's just a single dose, and it's not as widely used.
Exactly. And then the second question, it's not easy to read because you have to redo the entire study for every antibody. And so that's not so easy to do. That's why I think I'm personally very excited about this GSK product, because if the GSK antibody, which was found in the first SARS, works for this SARS-CoV-2, if it's in a region that just doesn't mutate, because if it does, the viruses can't propagate any longer, then we have an antibody that could be used for COVID-25, right?
That's good. That's basically a lesson from history, something we can use from the previous SARS-CoV outbreak. Very good, Dr. Chen. Dr. Wax, I think that just a question just popped in for you regarding other precautions with the vaccine in terms of allergies to other medications. If you want to comment on that and then conclude.
For those who have an allergy history to other medications, it's thought to be safe to go ahead with the vaccine. In certain conditions, the observation period is to be longer than the typical 15 minutes, which is currently recommended, and there would be a 30-minute period of observation. As mentioned from the reports from MMWR, almost all the severe reactions have occurred within the first 15 minutes. But again, those with histories of allergies to other sorts of medications, the observation window should be longer.
Thank you, Dr. Chen. Again, I want to thank you personally and on behalf of our participants for a wonderful presentation and Q&A. Same for you, Dr. Wax. I know you're part of our family, and but still, this was an excellent update, and I'll turn it back to you for conclusion.
Okay. Well, again, I would like to really thank Dr. Chen again for a wonderful and so timely presentation. And so we're going to continue this webinar series later on in the month. As some of you know, within this general webinar series of COVID-19, the medical and public health considerations, we have a kind of a nested series of webinars on disinfectants, which is funded through the CDC. And our next webinar on disinfectants will be on Wednesday, February 24th. We're going to talk about the toxicity of chemical disinfectants encountered in everyday life. And Dr. Kazi, myself, and other colleagues will be presenting this presentation. So all the prior webinars are summarized in our prospectus, which you can get onto our website. We've organized them, and it's really become somewhat encyclopedic at this point, and fascinating to look back on and how much we've learned over the 10 months as we've all tried our best in terms of dealing with this pandemic. At this point, I'd like to again thank Dr. Kazi and Dr. Chen, and wish everyone a good day, and please stay safe.